So in this video, we're going to discuss some strategies as it pertains to identifying a Stemi in the presence of a right bundle branch block. Now, this strip was provided to me from a paramedic that works with Santa Fe County. His name is Chris Serrano. He was actually a former partner of mine on the ambulance when I worked for Santa Fe County. And he is also a recent graduate of the Santa Fe Community College paramedic program. So Chris got called out to a 72-year-old male who had the complaint of chest pain, shortness of breath, and I think was also like fairly diaphoretic as well. And as you do in those situations, you'll get a 12-lead ECG, and this is what he was presented with initially. Now, when we look at this ECG, we can tell pretty quickly that this is in fact a sinus rhythm. If we look at here at lead 2, we can see that that is very clearly a P wave. This is a QRS complex, and then somewhere in this mess is a T wave. The rate appears to be maybe about like 110 times a minute. We've got a left axis deviation because we've got a negative deflection in leads AVF and a negative deflection here in leads 3. And we've got a predominantly positive deflection in lead 1. Now, the monitor does identify this as being a STEMI. It says meets ST elevation criteria. But keep in mind that in certain circumstances, particularly with those interventricular conduction delays, such as the left bundle branch blocks and the right bundle branch blocks, that abnormal depolarization can cause abnormal repolarization, and that can alter the ST segment in a manner to where it can kind of give you an erroneous diagnosis of STEMI when in fact it's that person's normal variant. Now, in this particular case, that was not the case. This man was having a full-blown acute coronary syndrome. And the reason why we're using this ECG as a teaching example is because it offers some good examples of like what to do if you're ever confronted with this situation, and maybe like the symptoms are a bit ambiguous, or maybe the interpretation by yourself and by the monitor is ambiguous. So when it comes to identifying STEMI in the setting of anything or any sort of a dysrhythmia, we're really focusing on that J point. That's what we want to identify. And the J point is the transition from the QRS complex to the T wave. However, in the setting of a right bundle branch blocks, that can be kind of historically difficult to identify. For instance, if we were to blow up lead 2 here and take a peek at it, we've kind of got a flat area in between the QRS complex and the P wave, and we don't really have much in the way as far as like a discernible T wave or ST segment. Now, some of you might look at this right here and think that is the ST segment and that the T wave is in fact right there, and you would be wrong in that situation, and we'll go over why. So anytime you're confronted with something that looks like this and it's kind of ambiguous, you're not really sure like, what starts where, it would behoove you to make sure to look in all 12 leads with the understanding that all 12 leads represent the same duration of time. And what does that mean? Well, that means that the time it takes for the QRS complex to depolarize in V6 is represented identically as the time it takes for that QRS complex to depolarize in AVR. So if we can find a lead that has very clear waves, in the sense that like the P waves are very clear, the QRS complex is very clear, and the T wave is very clear, we can use those distances in that lead to get a good idea as far as what the interval should be, and then apply that to other leads where those intervals are a little bit more ambiguous. And so if we look at our options here, it looks like V5 is probably going to be our best bet for identifying normal intervals. And we can zoom in on this one and we can see pretty clearly that in V5, we've got a P wave and we've got a QRS complex and we've got a T wave right here. And then this is the isoelectric baseline. And so I chose this complex here mainly because it's like pretty easy in the sense that the Q wave starts on one of the big box lines, and so that makes counting out boxes a little bit easier. I know the image quality is not great, but if you can imagine a straight line here, that's where the big box is. And then what we're going to do is we're going to count how many boxes go from, or how many boxes there are from the Q wave to the end of the QRS complex, which is right here at this location. And so when we do that, again, not a great example because it's a little blurry, but there's like 1, 2, 3, 4 small boxes, which means that the total duration of the QRS complex is 160 milliseconds, or 4 small boxes. And if we take this complex here and we start at the QRS complex and we draw a line straight down, we can see that it intersects at the would-be Q wave on this one in V6 below it. And if we take the end of the QRS complex and again just draw a line down, we can see that it also intersects and that the T wave, in fact, for this QRS complex in V6 is right here. So we know that at least in these two complexes that this would-be ST depression is actually not ST depression at all. It is in fact still QRS. So with that in mind, we can take that measurement and that understanding and apply it to some of these leads where it looks a little bit overwhelming and a little daunting. And so let's start and look at lead V4. So in lead V4, we have a complex right here. And in this complex, we have a Q wave, which more or less starts on this big box. And if we look at where that starts and then count out 4 tiny boxes, so that's going to be 1, 2, 3, 4, we can tell that the QRS complex should end right here, which means that this little notch is in fact the J point. Now that we have identified the J point correctly, we can measure this in relationship to the isoelectric baseline, which is here. And if we draw a straight line between those two structures, we can very clearly see that this is in fact elevated over the isoelectric baseline, and it looks to be about 2 millimeters of elevation, which means that in this particular lead, that is concerning ST elevation, and that is pathognomonic for a Stemi. Now, V4, we can put a little check mark. V4 has ST elevation. We've confirmed it, confirmed the J point, and we can move on to a couple other leads so that we can get that Stemi criteria, which is ST elevation in 2 contiguous leads and the presence of concerning history. So let's move over to V3 because V3 looks pretty darn awful. Now, again, we said that the amount of QRS complex that exists or should exist is going to be 4 tiny boxes or 160 milliseconds. And if we take, let's say, this complex right here, and we measure out from where the start of the QRS is, which is there, 4 boxes, that's going to be 1, 2, 3, and then our 4th box is going to be here, which means that right here is the J point. Then we can look at the J point's relationship to the isoelectric baseline, which is there. And yeah, again, we can see that this is pretty clearly elevated. Looks to be about 2 millimeters as well. And so this lead, or at least let me rephrase that, lead V3 also fits the criteria for a Stemi. So we can put a check mark there. We can apply this to the other leads like V2 and V1. And if we take, again, V2 here and measure that out, the QRS complex starts here. So let's see, it's about 1, 2, 3, 4. Again, kind of blurry, so it's difficult. J point's going to be that. T wave is right here. And if we take our line and just kind of draw a line across, we can see that the J point, again, is well above the isoelectric baseline. And so this also fulfills the Stemi criteria of being greater than or equal to 2 millimeters of elevation. Putting this all together, we have a person, 72-year-old male, who's got very concerning symptoms of acute coronary syndrome. We have an electrocardiogram that shows ST elevation of 2 or more millimeters in the anterior leads. And not only are they the anterior leads, but they're also in contiguous leads, because remember, V2, V3, and V4 are contiguous with each other. This patient is experiencing a Stemi until proven otherwise. And as far as the follow-up is concerned for this individual, sounds like he was very, very complicated as far as the degree of damage he had sustained to his heart and was actually transferred to a heart hospital in Albuquerque. And it doesn't sound like he did too well. But anyways, this is a good example of how to correctly identify Stemi in a right bundle branch block. I hope this provided some clarity, and as always, feel free to reach out to me with some questions if you should have them.